they're also advocates in ways that I think helps advance human rights for our clients. Donna Smith is an attorney that is, I think your position is called outreach. I don't know. You're going to say what your position's called, but I know that she's a big voice for the organization. It's a national organization that helps advance the causes of people planning for their best end-of-life choices, of which medical aid in dying is just one part of it. And I'm always wanting to learn more about how the laws are changing around the country, and particularly in the areas where I serve my clients, DC and Maryland. So, and also her partner is Wendy Miner, who is kind of her partner in crime. They're like a dream team duo. And Wendy is the name that many of you hear me say when I say, be sure to grab this booklet, Advanced Care Planning Toolkit, and you can contact Wendy Miner. So many of you know her name. And the two of them work together so beautifully and have different gifts. And I'm delighted that you're coming back yet again for another program at Iona. So thank you.
Thank you, guys. Thank you. So Wendy, I'll let you introduce yourself, then I'll introduce myself, and we'll get started.
Well, thank you, Dixie. I really don't have to introduce myself because Dixie has done that. I just want to say thank you again for having me here, having us here. I'm the Community Engagement Associate with Compassion and Choices, and I do many things, but one hat that I do wear and I keep on at all times is I do whatever Donna Smith asks of me.
Believe it.
So I'll give you the mic, Donna. Thank you again, everyone, for having us.
Well, thank you, guys. As Wendy and Dixie alluded to, my name is Donna Smith, and I am the Advocacy Director for Washington, D.C. and Maryland, as well as the Diversity, Equity, and Inclusion Advisor to Compassion and Choices, the entire organization. And with that, now we're going to see if I can share my screen.
You want me? Okay, you got it, Donna. I was going to share my screen so I could.
Okay, you do it.
Let me see.
I shared it with you.
Uh-huh.
I do all the talking. Wendy does all the work. That's how we.
What would you do without that?
No, I just have to stand up and talk. Okay.
There you go.
All right. So the topic of today is medical aid in dying in DC and Maryland, the update. Next slide.
Mm-hmm.
So just to go over, I'm sure most of you know, but for those who may not, medical aid in dying is a safe and trusted practice in which a terminally ill, mentally capable adult with a prognosis of 6 months or less to live has the option to request from their doctor a prescription for medication, which they can choose to self-ingest to end unbearable suffering and die peacefully. In DC, this is called the Death with Dignity Act, and it was excuse me, and it was passed in 2016, but it was passed in an 11-2 vote, which is a super majority. Most of these bills take 7 to 10 years plus to pass, and DC passed it in its first session. So give yourselves a hand. Dixie was there helping us advocate and lobby for this bill. And so DC now is in what we call the access phase, which means you've passed the bill, but now we have to continue to get the word out and educate medical providers and potential patients about what it is and their families about what this is and how to access it. Some of the eligibility requirements: you have to be an adult, you have to be terminally ill, and you need to have a prognosis of 6 months or less, and you have to be capable of making medical decisions. As you know, you can be terminally ill and not be within 6 months of dying, and so then this would not qualify you to use this. Next slide. Other requirements include that 2 physicians must confirm eligibility. Physician must inform person about other end-of-life care options. There must be 2 verbal requests and 1 written request. 2 witnesses must attest to the voluntary nature of the individual's request. And the person must be a district resident and able to take and ingest the medication themselves. And that means basically swallowing the medication. Or if you have a feeding tube, at least you have to be the one to press the button for the feeding tube. It cannot be a third party doing this. That would be considered euthanasia. It has to be, or second party, sorry, it has to be the person taking it and ingesting it. It doesn't mean you can't have help, but you have to be the one that actually swallows it or presses the button for the machine for you to ingest it. Let's stop here really quickly with, well, let me say this and then we'll have comments or questions. Certain provisions of the law. Wills, contracts, insurance, and annuity policies are not affected by a person choosing medical aid in dying because medical aid in dying is not considered suicide or assisted suicide. The disease is killing the person. The person is determining the where and the when, but 2 doctors have already certified that the disease is killing the person. Any questions or comments about the law so far?
You can unmute yourself or you can put something in the chat if you would like to. I don't see anything in the chat.
Okay.
So why don't you proceed and thank you.
All right. So there are some safeguards inherent in the law, and these are a short list of them. Really quickly, Wendy, why don't you read this for me?
Donna, I'm sorry. I'm having a problem with my eyes right now. That's why I don't have my glasses on.
Dixie, could you
I'm
read this
sorry.
for us? Could you read this? Thank you.
I can read it or Dixie, yeah, there you go.
End of life options safeguards. Only those with an incurable and irreversible terminal illness and a 6-month prognosis would qualify. The patient must be able to take the medications themselves, either orally or through their G-tube. Both the diagnosis and the prognosis have to be confirmed by 2 doctors, and both doctors must be assured that the patient is making the request on their own volition before a patient can be eligible for medical aid in dying. No coercion. Patients are not eligible simply because of age or disability. The attending physician must inform the requesting patient about all end-of-life care options, including hospice and pain and symptom management. If either doctor has concerns about the patient's mental capacity for such a decision, they must make a referral to a mental health professional for an assessment. Medication can't be prescribed until mental capacity is determined.
And Dixie, could we pause right there for a second?
Sure.
I love, Dixie has had firsthand experience in assisting people with this law, but this is very, very important. So as written, this law can take anywhere from 4 to 6 weeks, right? Because you need to have an attending physician, your primary physician, but if there is a hint that you or the person is unable to make this decision, then they must, by law, be referred to a mental health professional. So that's another appointment you have to set up. So, but that's very important to understand. This is not necessarily a quick process.
And I just want to say that the mental health clinician is going to distinguish between someone having depression because they're terminally ill and their life is coming to an end, or they might have like a Parkinson dementia depression, which is also a symptom that occurs, versus a classic, chronic mental illness where they are suicidal. There are differences, and the clinician needs to determine that.
Thank you, Dixie.
Okay, I'm going to go on. 2 separate requests for medication must be made, 1 oral and 1 written. Providers have civil and criminal immunity for participating in the law as long as they comply with all aspects of the law. Anyone attempting to coerce a patient is subject to criminal prosecution. A terminally ill person can withdraw their request for medication, not take the medication at all. And I think that 50% of the people who get the medication don't take it once they have it. And otherwise, they can change their mind at any point. So sometimes it's just a comfort to have the medication. Life insurance payments can't be denied to a family because a loved one uses the law. This is very important. And finally, no physician, health provider, or pharmacist is required to participate. And that's a real challenge in the district.
And so as you can see, no one is forced to do this law, not the terminally ill patient. If you decide to go through with this and you go to the doctors and you get, the final approval from all of the doctors and you get your prescription, you don't have to take it. You can go through the process and not get a prescription. No one's going to show up at your door and say, hey, Dixie, it's been 2 months. What's going on with the medication? It's totally up to you. Doctors don't have to do it. They will have to refer you. If the hospice or the hospital has a policy of neutral engagement, though, they have to refer you to someone who would do it, but they don't have to do it. Same with pharmacies and pharmacists. And so to that end, has there been litigation involving insurance companies? No, there has not been litigation thus far involving life insurance companies, because once it's written in the law that this is not defined as suicide, that's it.
And Donna, I want to just ask you a question. Shoot, I just lost my question. Okay, go ahead and answer that other question. I literally just forgot my question.
That's all right. Is hospice administration of morphine given with consent by patient? Can patient administer doses himself? So who asked that? Is hospice administration of morphine given with consent by patient?
I asked that, Ann Matheson. I was curious because it seems that would be a method of eliminating reality. It sounds like I don't know, does hospice have, maybe I should just withdraw the question.
No, I was just trying to clarify. So in Washington, D.C. and a number of states, doctors that do this want you to be on hospice. It's so helpful to have those wraparound services.
Yes.
Right? But this is a concoction of pills. It's more than just more
pain removing.
Yes.
Okay.
And they don't necessarily, so there are different roles that hospices can play, right? So Vitas in DC plays the second role. They support their patients who are in hospice who want to go through this. They're there to make sure they're comfortable, but they don't write the prescriptions, and they may or may not necessarily they don't write the prescriptions, but they're there in a supportive role.
To monitor it or whatever.
Yes,
You're
yes.
in hospice,
The patient is comfortable, so on and so forth. But I did, like I said, it cannot be a doctor that actually it's pills, so it's not really injections, but the person has to take control at the end because it's their decision.
And I just wanted to jump in. The medication that's provided by hospice in a comfort pack, like Ativan or morphine, it's really not enough to fully kill you. It's just enough to give you comfort, and it's very small dosing. So this medication is a compound with barbiturates and sedatives and cardiac meds and narcotics, and all together collectively it's a toxic dose.
I guess I only asked about morphine because I was trying to think of other ways that other people would not be able to meet these conditions, and they'd be sick and be under hospice. And
well, I have a very sad case. One of my cases that I helped with was a gentleman who was only 68. He had COPD. He was attached to oxygen, 100-foot cord oxygen in his home for about 4 years. And he did try to overdose on morphine and landed in the ICU. but it was a desperate call for help. And then he found out about the law in DC and he decided to do it, and he was successful and he had a beautiful death. But he tried to do it himself with the morphine, and it was very tragic. But I wanted to go back to my question, and that is the issue of, like, I wanted to ask Donna, across the nation, have there been any cases where people got the medication and other family members used it or sold it or used it in foul play? Because
None that we are aware of. And
Yeah.
it is in 11 jurisdictions at this point. And it's been in Oregon for about 30 odd years or so. And we have not had any record of that. But, you know, in terms of the disposal of these drugs, each state and each jurisdiction has their own law regarding the disposal of these drugs. And that's how these drugs should be dispensed. There is no particular clause in this law that tells you how to dispose of it, because you are supposed to follow your state's guidelines as to disposal of these drugs. And these drugs are already found in the marketplace. As Dixie indicated, it is the combination of all of them that makes it deadly. Excuse me. But also I want to bring up and for discussion that palliative sedation is what you guys were sort of alluding to and talking about. You know, the intent of palliative sedation is to make you comfortable, but we know that there are times when people die from the use of palliative sedation. The reason why some people see a difference between this is because of the intent. The intent is to make you comfortable, even though sometimes the result is the same. But palliative sedation is legal everywhere because the intent is to make you comfortable, even though the outcome in some cases is that the patient passes away. All right. Next, that was a good question, good discussion. Next, Wendy.
Okay. I think she's having trouble with her eyes, so I'm gonna medical.
No,
No,
it's
that's
changed.
Wendy. I'm fine.
I changed it.
You got it.
Yeah. Person. So let's talk about why medical aid in dying is not suicide. Excuse me. In suicide, when you deal with suicide, sometimes the person sees death as preferable to continuing to live. In the case of medical aid in dying, our terminally ill patients overwhelmingly want to live, and normally they do everything they can do to sustain their lives. But it comes to a point where death is imminent and their suffering is endless. And so they make the decision that this is what they want to do. But it's after going through a lot. And I just want to say that these laws were enacted in Oregon originally because patients with really aggressive forms of cancer and AIDS patients were just lingering at the end of life. They were suffering so bad and they needed this as an option. And so that's sort of the history and the background as how this law came into fruition. In suicide, the decision often is made in isolation. In medical aid in dying, the decision to lessen a painful death is discussed freely and thoroughly with doctors and other trusted individuals, including the person's family. Person who is suicidal is not considered mentally capable. That's in the case of suicide. In medical aid in dying, the person can not qualify for medical aid in dying unless they are determined to be mentally capable. The suicidal person usually dies alone. And in medical aid in dying, the person makes their wishes known, and often it is to be surrounded by loved ones at the end of their life. I see there was a question. Let's read that question. Okay, my mother was in hospice at her retirement community's nursing center. The visiting hospice nurse said she'd never seen anyone of such distress in the hours before her death. She hadn't been given the hospice comfort drugs. I don't know who did take her drugs. Sorry for that.
Well,
So I want to bring this up as well. if you are in a facility, or if your loved one's in a facility in Washington, D.C., and they want this, you know, part of the preparation for this is talking to the facility to see if they have a policy of neutral engagement. And if so, what is the level of their participation? I can't speak to why she wasn't beyond the medical aid and dying part of this, because that is something that you actually have to talk to your doctor about and go through a process. So it's not just given to everybody. You have to self-elect that. But in terms of palliative sedation, I'm not sure why that was not, it doesn't sound like that was an option for her.
It's probably because of nursing shortages.
Mhm.
That's why you have, on most facilities, you have one aide for 13 to 15 patients, and you might have an LPN supervising the whole unit. So it's all about nursing shortages. And if you're going to give narcotics, you need to be able to manage someone's pain. So if you really want to do end of life planning in your facility, you really have to plan ahead and have advocates asking the staff to give you the morphine.
And so the question was, does depression preclude you from this option? And it, as Dixie indicated, it depends. Like if you know that you are dying, that's a certain level of depression that may go along with that, but it doesn't make you incapable of making a health decision, where there is another form of depression that makes you incapable. And so the doctors and mental health professionals have to distinguish between that. Good questions. Okay. So these organizations, the American Association of Suicidology, the American Public Health Association, the American College of Legal Medicine, and the American Medical Student Association have all affirmed that medical aid in dying is not considered suicide. Next slide. Okay, Dixie sent out communication. Dixie, why don't you just say what you just sent out?
Well, if you have a history of suicide attempts or having a history of major depression throughout your childhood or teen years or adulthood, when you come to the place where you have a terminal illness, that's a whole different experience. And certainly that would be exacerbating it. But people who have a whole life history of depression likely would not qualify for this medical aid, which is, you know, maybe some people would say that's discriminatory. You know, it's a disability. But it's also a protection in the law so that people can't abuse it. That's why it's there.
Right. And so, you know, there are protections in the law to protect people that need protecting. And while I hear a lot as I go around the country and speak about this, there are people, for example, with Alzheimer's who feel like they should have this option. And currently the way it's going in the United States, as you can see, we have authorized this. It says 10, but now it's 11 because New Mexico joined this last year. Only in 11 states since 1994. It is a fight in every state. And without the protections as they are, we would even have less jurisdictions who have passed the law. We hope Maryland will be in the next round in 2023 of states who have passed this law, as well as we expect Nevada might very well be there. But roughly 1 in 5 adults now live in a state where medical aid in dying is authorized. And that's partly because California, who has 40 million people, are one of the states that passed it as well. But it's Oregon, Washington, Montana. Now, Montana is interesting. It did not pass legislatively. It went through the courts and passed. Vermont, California, Colorado, DC, Hawaii, New Jersey, Maine, and New Mexico. Next slide. So Compassion and Choices is in most states. I would say roughly about 40 out of the 50 states or so, maybe a little less. But if we don't have a medical aid in dying law, then we're there concentrating on our other goals, which is education in general around advanced planning and dementia. You would be surprised how many people don't have any advanced planning documents, who avoid the discussion at all costs. And so we do a lot of dementia education and advanced planning in terms of advanced directives and other things in states. But if we have volunteers though in most states, and the yellow dot shows you where we have volunteers. The navy blue states show you where there has been medical aid in dying introduced. And then the light blue states are where it has been authorized. Next. So before I get into the Maryland campaign, let's go back. Any other questions about DC? I'm going to come back and tell you what our needs are in DC, but I just wanted to provide that brief overview. Any questions about the overview in DC?
I want to ask you, Donna, if in DC, since we don't have statehood, are you concerned if we have a national political change that we could lose our right to this law?
I think that they could definitely push back up against it. The reason why we had such a hard time getting it, we got it passed. After it got passed, getting access up and running to the law was very hard, because at that time it was a Republican Congress and they were trying to, through appropriation, gut the law and not allow it, through lack of a budget, to have any teeth. Luckily, they got distracted with other things and that didn't happen. Before, at least 2 years after the law had passed, there was so much media about Congress fighting it, the Republicans in Congress fighting against it, that a lot of people in Washington, D.C. did not know that it had been enacted. And so we're trying to shore up the law now. One of the things we're trying to do is work with DC government and the mayor to ensure that low-income people can have access to the law, because the law is very expensive. The drugs are very expensive. And so private insurances carry it, but it's still a heavy load. If you don't have a private insurance that covers it, it can be upwards of $1,600 to $2,500. And so we're trying to get, like in California, Hawaii, they use their local Medicaid dollars to help low-income residents access the law. And so we're hoping that we can get the administration to do the same thing. We're just waiting for the change of administration, if there's going to be a change, to do it. But when we approached them before COVID, they were open. Muriel Bowser's administration was open to doing it. So we'll see. That's the challenge we're taking up now. I think it's harder to take something away once it's been embedded. And we're just trying to make sure it gets embedded. With the potential overturning, I'm reading a question, with the potential overturning of Roe, will personal autonomy for aid in dying be at risk? I'm afraid it will. But that's what we all have our eye on. While that presents a huge challenge, it also presents opportunities to partner and help each other through this. We're going to have a lot of struggles with personal autonomy if that happens, but we're gearing up for it and we're thinking about it. Good questions. So let's move on to the Maryland campaign. Are there any advocacy initiatives in support of Alzheimer's patients' right to die? That is something we're working on now. We don't really have a formed initiative yet, but we're doing the research to see what's feasible. We have some Alzheimer's documents that fall short of the right to die, but we'll pass that around. Wendy, do we have the electronic version of the advanced planning guide?
Yeah, I'll get you.
So while it falls short of the medical aid in dying because of the mental capability issue, there are some things that Alzheimer's patients can elect to do in terms of their most and their post documents, which are the medical orders of life-sustaining treatment or the physician orders of life-sustaining treatment. You can dictate if you don't want any extraordinary measures. And there are things you can say you don't want done to you if something happens. So it runs that gamut. So there are other ways, but there's nothing so far that goes as far as medical aid and dying. Affirmatively having that right.
Maybe you can send me whatever documents you have in this slideshow also, and I can share it with the group later on.
Great. Wendy?
Oh, yeah, yes. And then I'll also send the documents. I was just gonna put them in chat after I stop sharing my screen.
Well, if you don't mind emailing it to me, then I can email it to people who might have registered.
Okay, I'll do that. I'll
Great.
definitely do that.
Thanks. Okay.
You're welcome.
No, the Medicare does not cover the drugs. There is in terms of federal law, this is still considered suicide. Our tactic is to address it through the states. And once we get enough states to pass it, then we will introduce a federal law. But because from a federal perspective, this is still considered suicide, the federal insurances won't cover it. Okay. So in Maryland, the act, it's called the End of Life Options Act, and it was introduced in 2015. It was sponsored by Delegate Shane Pendergrass of Howard County in the Health and Government Operations Committee. So we call it the HEO, JUD, Judiciary. It's a dual committee. And in the Senate, it was sponsored by Senator Jeffrey Wallstreicher in the Judiciary Proceedings and Regulations Committee, JPR. So that was in 2015. By 2019, we had such momentum that it actually came out of the committee on the House of Delegates and off the floor of the House of Delegates. So it passed the House of Delegates totally. It then crossed over to the JPR committee and it came out of that committee, but it died on the Senate floor in a 23-23 vote, which rarely, if ever, has happened before. Then, though the bill was introduced the following years, it was introduced in 2020, but because that was when COVID hit, that session was short and it died. In 2021 and 2022, the Senate sponsor requested that it not be introduced. They were dealing with COVID issues. So it will be introduced in 2023. And we are still, because there's a big election, we think that we still have the votes in the House, but we have to see post the election. But in the Senate side, we still are 2 or 3 senators short from passage. But we do believe this year is the year. Next slide. Any questions on, before I get into DC access, any questions on Maryland? Let's see. Are there any improvements we can make in DC that follow the recent changes in California and the residency requirement in Oregon? Okay, so let me talk about access first and then I'll address that. So passing a law that authorizes medical aid in dying is just the first step. Ensuring people understand the process and have access to supportive healthcare systems is at the core of the access campaign's goals. So the goals and access campaign is, which is where we are in DC, is educate the public, empower individuals, educate healthcare systems, provide assistance for supportive policy development. Next slide. Dixie, could you take over this slide for a second? Up.
DC, well, you all just gonna have to excuse me getting close
Dixie's
to the
there.
screen. Oh, okay, you got it.
Okay, you want me to read this one? Is that what, yeah, okay, so DC Access Campaign, passing a law that authorizes medical aid in dying is just the first step. Ensuring people understand the process and have access to supportive healthcare systems is at the core of the Access Campaign's goals. Hospitals and hospices with neutral policies, GW, Sibley, MedStar Hospital Center, Kaiser, Vitas will not write the prescription, but plays secondary role. And I can just say as a clinician that this is definitely the biggest challenge, is finding pharmacies, doctors, hospitals, and hospices that will embrace this human right that we've established as citizens in the district. And it's a real pushback. It's a heartbreak for me because I have witnessed time and time again that the hospice nurse in particular has been full of judgment. And even if she's been a hospice nurse with the family for a long time, she steps back and the family tends not to share with the nurse what their plan is because they feel judged. And nobody should feel judged when they're making a decision about their own care and their suffering. And it's really been heartbreaking to witness that at just about every single time. So we need to get our hospitals on board, and people should have a right, because if they're in a facility, they should be still able to access the law. Are there any improvements we can in DC? So, I mean, I don't know if other states have the same challenges, whether they have more pharmacies and doctors who prescribe. One of the challenges in DC is that there's only one pharmacy, Grubbs, that will write the prescription, and that's a small local pharmacy. And if you are aware, we have lost two wonderful pharmacies in DC, Fours and Brookville. Well, they closed Cathedral. Now Brookville's still open, but I worry about Brookville Pharmacy because the larger corporate pharmacies are really taking over, Walgreens and CVS. So right now, Grubbs is the only pharmacy that will write the prescription in the district.
And thank you. I know we were discussing that last week about the pharmacies, and they do have, this is an option, you know, the pharmacies, if they want to write the prescription. I think it just goes back to saying we have to continue to educate, to continue to help people understand what medical aid in dying is. Right. And so Donna had just mentioned that even though the law is passed, we have to get out in the community and educate people, pharmacists, hospitals on what this is, so people can, we have the law, but they can't get access to it because of the pharmacists and doctors.
And another feature is, I remember having a conversation with the Fours pharmacist before they closed, and I asked him why they don't participate, and they said that they actually wanted to participate, but the compound, the medication was created in Maryland. And so because Maryland didn't have the law, they weren't able to access the medication ingredients. Yeah. So that's why Forrest was unable to do it. Yeah. But in terms of neutral policy, when I worked for community hospice and I attended the hearings for DC law, there were several down at the Wilson building. I would come back to work and I'd ask my coworkers why we weren't more engaged in this. And the physician at hospice told me that they were neutral. And I think being neutral is kind of a hard place to be. Like, you know, like if it's a law on the land in the city and people, that our business is helping people die well, I think being neutral is a kind of a hypocrisy in some ways. Like, I don't know. I just felt like we need to say that if our clients are taking advantage of the law, we need to support them. But hospice was clearly neutral. However, VITAS, I have gotten referrals from the VITAS physician there. So I think they tend to be not as passive about it.
Are there any questions? I'm gonna,
Sure, go. I mean, there's some, I think you addressed the questions in the chat here.
I have a question. Is being neutral, does that mean they won't help you with this?
Yes, correct. You're pretty much on your own. And like I said, that I participated in 4 or 5 actual completions, and the hospice nurse was not anywhere to be around. She was not told. And at the time of death, I told the family, we're going to call the hospice nurse and tell them that the patient died, and no questions asked. But I'm sure the hospice nurse put 2 and 2 together because it was a sudden death. But if they just kind of look the other way.
but Donna, doesn't like, if you're neutral, isn't that good as far as, but rather than a hard no? That's the discussion we were having on if a hospital or something is neutral compared to a no.
When we first started this, we were looking for supportive policies, which meant that you would absolutely do this. What we changed is to neutrally engaged, which means if they had patients that wanted this as an option, they would support it, but they wouldn't necessarily promote it. I think that helped some hospices deal with, the varying opinions within their boards. So that was the position that was more embraced. So we call it neutrally engaged, meaning that they'll support their patients in whatever their patients decide to do. Then there are some of the hard no's, which of course, a lot of the religious-based hospitals like Georgetown University is Catholic, they will never be supportive. Mm-hmm. And so that's the difference.
They don't even call it with the proper name. They call it physician-assisted suicide.
Right. And our position is the physician is doing nothing other than writing a prescription, which they generally do. Mm-hmm. The physician does not have to be there at the time it's taken. The physician is doing nothing. The patient is dying of the terminal ill disease. Mm-hmm. Is there an official document one can share with his or her family to express desire for the option? No need to apologize. Yeah, this can be expressed in your advance directives, in your living wills, in your most or post. So let's talk about most or post. Those are the directions or the communique between patients and their doctors about what you want at the end of life. Your advance directive is the communication between the patient, the terminally ill patient, and or the patient, they may become incapacitated about what you want done at the end of life. But that's really with your family and loved ones and friends. And so there are various ways to communicate it, but you need to put that on record. And in DC, there's a whole process you have to go to. Once you identify a doctor who will support you through this, that doctor then submits information to the DC Health Administration about it. And there's a list of things that doctor must do to make sure they are in compliance with the law. It's not really the patient that has to do it, it's the doctor that has to make sure that the law is in compliance. Who heard me talk at Martha's table last week? Yes. Hey, we had a good time, didn't we, Dixie?
That's great.
Okay, I'm sorry for the interference. My AC has gone out and I have to make sure the AC man fixes the air because I'm having a rough time here. So pardon me for running back and forth. So the real impact the access campaign can make So each year, the list of physicians who will prescribe goes up. And that makes a huge difference in terms of access for patients. And as the list of physicians go up, the ability of the patients to thoroughly access this has gone up. Now, DC Health is supposed to do a yearly report. They have not done a report since the advent of COVID. So since 2020, we are waiting for the last 2 years' reports. The fiscal note in the law said they expected roughly about 10 patients a year to use this law. The last time I spoke to someone in the DC office about this, they said last year 20 people started the process to use the law. Now, there are a number of reasons why people may not finish the process. They may change their mind. They may die before the process is over. But we know at least double the amount they expected last year started the process. I just don't know, because the report has not been completed, how many completed the process, but we know the number of users has gone up. Unfortunately, in DC, the number of physicians who are participating in this has stayed static at about 2 or 3, and those 2.
It's a seminar that I wanted to watch.
I'm sorry, can someone put themselves on mute? And those 2 are near retirement. And so we really need to do a better job of getting more physicians on board with this. Secondly, the national chains, pharmacy chains, are not supportive of this because they're national, right? But so it's always the local mom and pops, and in DC it's Grubs. There were 2, but now this one is Grubs. And so we need to really support Grubs, but also look for if there are other mom and pop chains in DC that we can have use them to get the medical aid and dying drugs, make them available to patients who need it. So we're having our own sort of issue with doctors and pharmacies being available to support the patients who want this in DC.
And I just want to say that as a patient, you're a consumer and you need to vote with your money. And you need to tell your doctor who you've chosen, they haven't been given to you, you've chosen your primary care provider. If this is something that you want, you as a consumer should say to your provider, I would really like this possibly as a possibility of part of my toolkit. And are you willing to write the prescription? And if they say no, I would challenge them why. And then just say that maybe at the end of my life, I'm going to need to switch providers. This is really important. And there's a lot of my patients who will say, do just that. They will talk to their provider, usually a geriatrician or a concierge doctor, and they've been told they're not going to write the prescription. So that doesn't give them much comfort.
And so there was a question that said, how can we, are there any improvements we can make in DC to follow the recent changes in California and Arizona? Yes, we can work with the mayor's office and DC Health to allocate the local Medicaid funding. And that's what we're trying to do now, set up those meetings to see, what's the process, how we can move that along. And in terms of the residency requirement in Oregon, so there has recently been litigation in Oregon because just like DC, and forgive me, I'm running back and forth, so it's not at the top of my mind. There's a state adjacent to Oregon where, just like DC, their residents may live in one place, but their doctors are in Oregon, so on and so forth in another state. There was a lawsuit recently that got settled where a patient who lived outside of Oregon, but whose medical provider was in Oregon, wanted to use the law. And they sued and they won. It was in a settlement. So the residency requirement in Oregon through litigation has been expanded to non-Oregon residents, right? Who have medical providers in the state of Oregon. However, the issue is you cannot live outside of Oregon, go to your medical provider in Oregon, get the medication, and then go home and use the medication. You must use the medication where it is legally acceptable to use the medication. So you would still have to stay in Oregon to use the medication. So that suit just got settled, I think in May. So it set a certain precedent, but I don't think we are at that point in DC, Maryland, and Virginia where we are there. Like I said, Oregon has had this law the longest, for 30 odd years or so. And, you know, DC actually couldn't handle a huge intake of people because we don't have the doctors or the pharmacies to support that at this time. And so while that might be something we look at in the future, I just don't think for this time we're ready. So we think Maryland will be the next one in the area to pass the law. And then Virginia has introduced the law, and I think they'll be coming along in the next 2 or 3 years. And maybe once we're closer to that and we have identified some more pharmacies and some more doctors, that may be something that we look at. Next slide, please. So these are some of the resources. We have a doctor-doc consultation service for physicians. So if you talk to your physicians that you have and you tell them that you want this as an option for you and they need to talk to another physician about it to see how they can get involved, that's the number. There's a Truth in Treatment initiative that talks about making sure you understand your prognosis and your diagnosis and how to speak to your doctor about that. Some good end-of-life information links in there. And we have the Find Care tool we don't have anymore, but there's some more DC Death with Dignity Act. There's a website that has great information. Next slide. So if you are interested in joining the DC Access Action Team, you can certainly get in touch with me or Dixie. The folks at Iona have our emails. I said me or Dixie, Wendy, I'm sorry, me or Wendy. The folks at Iona have our emails. You can connect us with groups or organizations that would like to have a speaker to give a presentation. You can also connect us to medical professionals who want to learn more about the law. And if you are a medical professional, become a champion by connecting us with your organization. So the action team we have in DC, we are constantly looking for more members, but it's a group of volunteers that work to educate and empower the public to get the care they want at the end of life and to have full access to their full range of options. Volunteers help normalize or mainstream medical aid in dying into the standard practice of care by empowering communities, and they are crucial to protecting the law. Next. So our engagement is with the community, but it's also with health systems. All right. So our next step is, if you're interested in joining the Access team, please let us know. We provide trainings, and our next orientation will probably be in September at some time. So with that, are there any more questions, comments, or concerns?
So in order to find out about they should email you and you'll put them on the list. And and you get, okay, great. Or you can go to the website, right? And sign up there.
It's easier to email us. Our website is under construction and it's not that user friendly yet.
Okay, great. There's a later question. What happens when a patient has dementia? There's a lesser opportunity to provide consent. I think you might have covered that, but
Yeah, I think I covered that. In terms of, read it again, I'm sorry.
What happens if a patient has dementia and has a lesser opportunity to provide consent? Is there a way to provide consent in advance of the dementia onset?
Consent for medical aid in dying, no. There are other things a person with dementia can do, like voluntary stopping of eating and drinking and so on and so forth. But in terms of medical aid in dying, they cannot provide consent because you must have the mental capability at the time that you are requesting the prescription.
But you can beforehand fill out a post or a most and then.
Yes, but that doesn't get you to medical aid in dying, right?
Right.
It gets you to other options at the end of life, yes.
And I'll send you those documents also, the advanced directive and the post forms. So I'll include that in the email to you.
Thank you so much. And I'll forward that and this PowerPoint presentation to the group later on. Yeah. And I'm going to post this presentation on our website someplace, and I'll let you guys know where that is when I do it.
Thank you guys so much. Such great questions.
Yeah. Thank you. Does anybody else have any other questions? I'm going to.
I see one question. Is voluntary stopping eating and drinking considered suicide? No. It is comparable to the doctor turning off the feeding tubes or turning off the oxygen. Those things are not considered suicide.
Okay. I will send these emails, addresses, and websites probably tomorrow. And okay. Thank you guys for a great.
So much, Donna and Wendy. You guys are great.
Yeah.
Thank you. It was a team effort. Thank you, everybody.
Thank you.
We hope your air
Hope your air conditioner's working down there in North Carolina.
Yeah, and again, if some people joined us after I said that, if you just found out about Around Town DC, please go to our website, aroundtowndc.org, and sign up for our weekly newsletter. And feel free to register for any of our in-person or virtual programs. You do have to create an account on the upper right-hand side of the website. So or you can email me at lfreeman@iona.org. We really appreciate you guys joining us today. It's such an important
Thank you.
Thank you, Dixie, for introducing us and facilitating this.
Pleasure. Be an activist.
You're a great example of that. So thanks. All righty then. So it's any last.
And if you live in Ward 3, consider voting for Matthew Froman.
It's done.
Yo, thank you.
He's going to make sure that we have expanded end-of-life choices in the district because he's about justice. He's got a history of justice in the city.
Thank you, Dixie. All right. Have a nice afternoon, everybody.
Bye.
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 Okay, thanks, everybody.
Thank you.
Bye.